All right. Well, thank you everyone for coming and joining my talk today. I'm happy to be here. As Kelly said, my name is Janelle Heddings. I am a pediatric psychologist here in the Department of Behavioral Medicine and Psychiatry through WVU in Morgantown. Um, I've been practicing for about 10 years now and have had different experiences with chronic pain. So I'm excited to share some of that with you all today. Let me see if I can get going. So today I'm going to just kind of orient us to chronic pain and just what that definition is. And then we'll run through very broadly the evidence-based assessment of pain and evidence-based intervention for pain. And then hopefully leave lots of time for questions, concerns. If you have any patients that you would like to talk about and have some discussions about that, I'm happy to spend some time talking through some of those things with you all. So just to orient us to pain and chronic pain in children, actually recent data from 2024 has come out to suggest that about 1 in 5 children worldwide experience chronic pain. And you can see the numbers here about what is the most common pain, with headache and a musculoskeletal pain being the most common pain that children are experiencing. But you can see almost a quarter of kids are experiencing pain in some different areas or general pain as well. We know pain tends to be more common in girls than boys, and it's typically more commonly seen during adolescence in that 14 to 15-year-old age range. Pain is very costly, and especially pediatric chronic pain. You can see costs about $19.5 billion per year in the United States alone. When you compare that to other chronic illnesses, more medical illnesses, it far and away is way higher than that. So chronic pain is a huge deal, both for the individuals, but then also, of course, how much it costs the patients and families. I'm not going to spend too much time here, but just important to highlight how the definition of pain has evolved over time. So in 2020, the International Association for the Study of Pain came out with a revised definition of pain. Before that, we were using a definition of pain from 1979. Really, the main highlights and what is so important about pain, and when we're talking about chronic pain, is that pain is always a personal experience and it's influenced by biological, genetic factors, by psychological factors, and by social factors. That's really important. A lot of my experiences working with individuals with chronic pain feel really frustrated, feel like they haven't been heard by their providers, feel like they haven't been validated. And I have worked with a lot of providers who will say things to me like the pain they're experiencing is out of proportion with the injury or doesn't fit with what has happened to them. So it's important to keep in mind that actually the definition of pain is that it's personal experience. It is not something that an outside person can judge based on looking at them or based on the injury. So all pain should be respected, but definitely we know it can have adverse effects on function, social, and psychological well-being. We also know, I mean, there was a time long ago when we didn't think infants experienced pain. We know that verbal descriptions of pain is not the only way um, uh, to express pain, and we can do a lot of behavioral rating systems to understand pain, even in individuals who cannot express that, whether it's a young child, whether it's a person or a child with a developmental disability, we can still assess their pain. So speaking of assessment of pediatric chronic pain, just some kind of ways to orient you to the kind of classification of different pain disorders that are out there that are some of the most common ones that I definitely see. So chronic pain, when we talk about chronic pain, this is persistent or recurring pain, or pain lasting for at least 3 months. So in order for it to be considered chronic, it has to be at least 3 months. Most most providers are considering and classifying pain as a primary disorder rather than or versus a symptom of another condition. So what I mean by that is that the chronic pain is due to this primary disorder that you have. And what I have listed here in this top row, these are disorders that would be considered chronic primary pain disorders. So fibromyalgia or functional abdominal pain. These are disorders that we believe that the chronic pain is that it's a chronic primary pain disorder. Versus some of the ones that are listed in the bottom, we know that the chronic pain is a symptom of another condition. So neuropathic pain could be a symptom of an individual who is going through or has gone through cancer treatment and has received radiation. We know that Ehlers-Danlos syndrome or EDS is a genetic disorder that can be associated, or that chronic pain can be associated with it, but not everyone who has EDS will experience that chronic pain. So just some ways to think about it. For me, as a psychologist who is treating individuals with pain, with chronic pain disorders, for me, how it's classified or what the medical diagnosis doesn't really change how I'm going to approach treatment, but just things for you to keep in mind that if individuals, your medical colleagues can really have different names for how we treat it is going to be very similar. In the DSM-5, our diagnostical and statistical manual that we use for diagnosing mental health disorders, there's not really a specific one that we use. I know in the past I've used things like a somatic symptom disorder with predominant pain or psychological factors affecting a medical condition. I don't really feel like those maybe really capture individuals who are struggling with chronic pain disorders. And a lot of folks do use more of an adjustment disorder diagnosis as well to really highlight that we have this stressor, we have this physical chronic pain going on, and we're having a hard time adjusting, or we're having a lot of stress associated with that diagnosis. Of course, a lot of individuals that I treat with chronic pain are coming to me with a lot of different diagnoses, such as generalized anxiety or major depressive disorder or OCD or social anxiety. So obviously, individuals might have additional diagnoses and are not usually just coming for specific the specific chronic pain. Excuse me. So when we think about assessing pediatric pain, there's a couple of ways we can do that. And a lot of these measures are things that I have used in some of my outpatient pain clinics. And there are things that we do pretty routinely every time we see the patient. So the one, first and foremost, is a functional disability inventory. So this is readily available and widely used. It's a great tool to just kind of see how this pain is impacting your daily functioning. The higher the score, the more that this pain is really impacting how you're functioning. And so it's a great kind of baseline tool and measure to use every time when you're treating patients with chronic pain. If you're working more specifically in the migraine or the headache world, there is it's like a functional disability inventory, but specifically for migraine disability. And that is readily available through Cincinnati Children's Hospital if you are interested in using that one. Beyond that, we can measure kind of how individual's pain is feeling right in that moment using a variety of tools. Now, a lot of these can be used for acute pain assessments and are used for that purpose. But in the chronic pain world, you can still use them if you want to have a good measure of following how their pain is going over the course of your treatment or the time that you're spending with them. So you might use things like the FACES Pain Scale Revised. You might use more of a visual analog scale for younger children. You can also use numeric rating scales and then behavioral rating scales. If anyone is interested in them, there's a lot that have been developed that help us determine pain in younger children or nonverbal individuals as well. There are pain-specific assessments of emotional functioning, and these are, for the sake of time, I didn't list out, general assessments of anxiety or depression or behavioral concerns. But of course, those for sure can be used when we think about assessing pediatric pain and all the parts that encompass pediatric pain. So I wanted to focus on the pain-specific ones. And these are measures that I've used in some of my outpatient pain clinics as a way to kind of see how impactful this chronic pain has has been for this individual. So there's a lot of ones listed here that are really important, can be really valuable for using with children. So first and foremost is pain catastrophizing scale for children. Um, there are models of catastrophizing that happens. And again, for sake of time, I cut that out of my talk, but I'm happy to talk about it more. But catastrophizing in pain in individuals, in children with pain, is usually very, very high. And it can be a area that we are going to work directly on in terms of treatment for those individuals. Some of these other measures are really great just to understand cognitions and if there's any fear of pain to help inform our treatment approach. Another really good one that we've used a lot is just kind of how the adult responds to children's pain. And in pediatric chronic pain, we can't forget about the family. And there's a lot of the treatment that we focus on involves the family because there can be a lot of parental attention or parental accommodation to pain that we need to address in order to move this child to better functioning. And so this ARC questionnaire can be a really helpful one to just kind of get some feedback on what the parent is already doing. And a lot of times in our pediatric patients, we also have their parents who might also be dealing with chronic pain as well too. So this can be really helpful for us to understand and target some of those things in therapy. I am currently in my headache clinic that I'm doing with one of my medical colleagues, using this tool as a way to kind of determine what level of care our patients need. So I'm not embedded in all of the headache clinics here at WVU at our children's hospital. So we use this pediatric pain screening tool to help us identify and screen who would benefit from that multidisciplinary pain or that multidisciplinary headache clinic. So this is a really great tool, well validated, super quick and easy that we are using to kind of sort our patients into what level of care they might need. So low risk, medium risk, or high risk. So definitely a great tool to help you when psychology services or behavioral health services are not readily available and you don't need to see every patient. This can help you identify those ones who maybe need that extra support. Okay, so I'm going to move into the treatment of chronic pain. And really the goal of effective pain management is to avoid this cycle. And this is kind of a common cycle that I hear, whether I am doing outpatient therapy or whether I'm in a multidisciplinary pain clinic. This is usually what happens is we have a patient request help for persistent pain. They maybe go to their PCP, their pediatrician, or a medical provider who maybe just focuses on biomedical symptoms and orders tests, which is not necessarily the wrong thing to do. We kind of want to see, okay, is there something going on that we need to address? Pain is adaptive. It usually tells us that something's wrong. So that's not a wrong thing that the provider is kind of evaluating those things. But then what happens is those tests come back normal or negative, and nothing seems to be helping this patient's pain. So the physician's happy and feels like the patient should be happy because there's nothing wrong. They don't need surgery, but they're not. They're really frustrated because they are still physically experiencing pain. And so then at that point, the physician might turn to stress or anxiety or depression. And that's when patients start to feel like they feel invalidated. They feel like the physician is saying or giving them the impression that it's all in their head, that they're making it up some way. And that's when the patient might request more tests or might request a second opinion. Physician might become really irritated, and then they refer them to a specialist or the patient doctor shops or things like that. And so this cycle creates a really negative patient experience. And I'm often, if patients actually make it to my outpatient general psychology clinic, they are often really frustrated by this. And so we want to, in the ideal world, we would have behavioral health services embedded in a lot of these areas where pain symptoms are present. I know that's not always realistic, but just kind of things to keep in mind, that this journey that individuals with chronic pain have might be really lengthy, and you might have to spend some time working on validating their experience, so that they can trust that you know that their pain is real. There's definitely different levels of care for pediatric chronic pain. At the top level, we have inpatient pain rehabilitation programs. We do not have any of those here in West Virginia. Some of the closest ones would be at Cleveland Clinic or at Nationwide, or out in CHOP, or Johns Hopkins also has one. So there's definitely some around, and I've sent patients to various one of those rehabilitation centers. There's also intensive outpatient pain rehabilitation, so they're not admitted to the hospital, and this really just depends on how the program is set up in insurance. But really, an intensive outpatient is going to be daily treatments for the individual's chronic pain. It typically includes daily physical and occupational therapy, maybe some aqua therapy, daily psychological care or group therapies, and either daily or weekly kind of family sessions, family therapy sessions, because that's a really important part of that. These, again, are in some of those places that I mentioned. Before I came to West Virginia, I worked in Kansas City, and we had an intensive outpatient pain rehabilitation program as well. So those are also kind of spread throughout the country as well. Another kind of level of care then after that intensive outpatient would be outpatient multidisciplinary pain clinics. There are just one at my previous position. I worked at a complex pain clinic where we saw kids with all kinds of pain disorders, but definitely there can be ones that are more specific. I know in my current position, like I mentioned, I have a multidisciplinary headache clinic, and hope to continue to expand some of psychology's involvement in other areas and make pain specific kind of clinics. And then lastly, kind of what I do in addition to my multidisciplinary clinic is just more traditional outpatient behavioral health services, which can be challenging because a lot of times you have to coordinate things amongst providers, but can be done. Before we launch into kind of treatment and what that evidence-based treatment looks like, just an important note that pain expression obviously varies by age when we're thinking about kids. And here you can see kind of what happens with young children versus school-age children versus adolescents. Kind of flows on nicely with kind of their cognitive abilities and what they're thinking at the time. So really what this means is that how we're going to treat the pain is going to depend on their age. For any young children or school-age children, I focus more on behavioral strategies, and we're really involving the parent. And a lot of times it is a lot of maybe behavioral strategies to increase motivation. Maybe it's decreased attention to the pain symptoms and increased attention to the active coping or the positive coping strategies. So it's a little bit more focused on that family involvement. Versus adolescents, where we might do more independent therapy, really working on improving their self-efficacy and being more preventative or proactive in their coping, which kind of lines up nicely with their desire to be independent. So just to kind of things to keep in mind and what it looks like. Having said all that, I will teach coping skills to young children, adolescents, and so we still will teach the same skills. We might just involve more parents for more of that behavior management piece for younger children. So psychoeducation is the first step of treatment, and I think a lot of it really helps to validate the patient that you understand that their pain is real, that it's not all in their head, and really just spending a session or two or some time to talk about how pain can be adaptive, and why chronic pain becomes a problem. And again, for the sake of time, I didn't have time to go into all of this. I'm happy to explain it, but I really do usually spend time talking about these things and providing that education. And I've included some good videos that I have found and I use all the time for this education piece. For most of my patients, as a pediatric psychologist, I'm seeing most of my patients do have medical and psychological disorders. So I'm always talking about the mind-body connection and making sure that they recognize that the mind-body are connected, right? and actually pain is processed in the brain. Like your pain is in your head. So I wouldn't necessarily say that to a patient, especially if they're saying that I think they're making it up. But that is where pain is processed. And so it's important to give them this understanding about that mind-body connection. And so I'll pull out graphs or I'll draw things for them to kind of describe how pain is processed. For older adolescents, I might use the graph on the left where we talk about nociception and how it goes up the spinal cord and processed there and comes back down. For younger kids, we might use the pain gate theory of pain, where we are talking about this gate that either opens to let the pain signal out or closes to block the pain signal. And how we open and close that gate is really dependent on kind of areas in our brain, how we think about pain, how we're feeling at the moment, those kinds of things that are going to help block and shut that pain gate. So that can be a really helpful metaphor to use while you're doing that treatment of chronic pain. I did include, and I'm not going to go into detail here, it's kind of some of the medical treatments of chronic pain that individuals have used. Obviously, there's nothing that's going to be, this is going to take away all your pain. A lot of times it is treating some of those other symptoms, whether they have other anxiety disorder or depressive disorder. But these are some ideas and some things that can be used and have been used to try to help individuals with chronic pain. Desensitization is typically used for individuals who have that amplified musculoskeletal pain syndrome, or the AMPS. And this is for individuals who, with their chronic pain, if they have a lot of sensitivity to touch, like they can't even, brushing on the area is just really painful. Desensitization would be having them actually touch or use different sensations or pressures on that area to desensitize those nerves to get them to stop responding. So just some ideas of some medical treatments. There's also a whole host of complementary and alternative treatments that are available for individuals with chronic pain. I know I think she's still doing it, but one of our gastroenterologists had an acupuncture clinic and was doing acupuncture, which I've had a lot of patients find a lot of benefit and relief from that. In the previous clinic I worked in Kansas City, we would see patients, the psychologist would see a patient, the medical provider, and then also a massage therapist would see a patient too. So if anyone can ever get any funding for a massage therapist in their pain clinic, that would be amazing and is really beneficial for individuals. But some other things here that you can recommend. My approach is if they work and are not causing any harm, that's really great. And so we see a lot of patients benefit from things like yoga or Reiki, traditional kind of Chinese medicine, kind of Eastern medicine things as well. So we kind of look at, in terms of the treatment of chronic pain, we look at patient focus. So what are we going to do individually with the patient, and then what would be family focused? So we really take kind of a rehabilitation model and approach where we focus on improving those independent functioning and building skills. Collaborating with other colleagues can be a really important part of treatment of chronic pain. But one of the most evidence-based treatments of chronic pain that we have is cognitive behavioral therapy. That's going to involve a lot of different components, a lot of different parts. I'm not going to, for sake of time, I'm not going to go into specific ones, but I'm happy to. But I wanted to list out different things. I've listed under CBT biofeedback, which can be its own separate treatment approach for chronic pain and can be really effective for individuals. You can also buy little, heart rate variability kind of things to use and to kind of teach individuals to relax using some of that, to give some of that biofeedback as well. Of course, with CBT, we're going to be working a lot on that fear of pain and catastrophizing using some of that cognitive therapy. Sleep might be a big part of what we're doing as well. Outside of cognitive behavioral therapy, another evidence-based approach to treatment for pediatric chronic pain is acceptance and commitment therapy. And these would be kind of some of the areas and things that ACT would intervene on. I know lots of, with my own patients, I'm pulling in components of this as well. So a lot of mindfulness and value identification is a big part of what I do with patients. And then when we think about family therapy, family focused, we might recommend or we might recognize that we need a more specific family therapy based approach. So dyadic or family cognitive behavioral therapy has been shown to be effective for individuals or children with chronic pain. And so those would be kind of areas that these therapies would target, would be working on that. I do think that if you don't feel like family therapy or if there's not something like that available, part of your treatment is really important to have the child move towards functioning. And I already mentioned this, but decreasing attention to pain is really important. And this is important in all settings. So if you see a patient with chronic pain, validating their pain experience, but then coaching them to use those positive coping skills. We might also, within that cognitive behavioral therapy framework, be doing a lot of goal setting and reinforcement, whether that's with a sticker chart or other ways to reinforce. We might be doing some things of those natures. And we can also use some of those behavioral approaches for other health maintenance behaviors. Like in my headache clinic, drinking water is really important. So we might set up a reward system to help encourage and motivate them to drink water, which in turn is going to help their pain. And then school, I obviously could probably do a whole talk just on school interventions, but I think what I'd say here is that attending school is a really important part of functioning. I think that currently I have a lot of patients who experience a lot of chronic pain and miss a lot of school. And so then move to virtual school to not get in trouble with truancy, which definitely is avoidance. And so, I try to work really, really hard with my patients to figure out what are the accommodations at school, how can we get you back to school if needed, how can we keep you in school and be successful and not necessarily avoid this the school setting, which only kind of reinforces some of that limited functioning that is happening with chronic pain. So common recommendations, things that I recommend in 504 plans could be kind of these sort of things. So that's always my first step. Happy to talk more about that if there's any specific questions. A big part of it is if the child is staying home, we want to make sure that there's no secondary gains, that they're not just staying home and playing video games all day, that they're doing assignments, that they're doing schoolwork, and that access to those things are limited. So yeah, I could spend all day talking about this part of it, but it's so important for kids to function and go to school. That's a big part of it. So as much as possible, try to make accommodations work. So in summary, pain is a common and costly pediatric complaint. Pain is definitely real. But we know that effective assessment and treatment of childhood pain definitely can improve outcomes in adulthood. And I think that's really important. There's a lot of research suggesting that children and adolescents who are experiencing or struggling with chronic pain go on to also struggle with chronic pain in adulthood. So it's really important to target it at this age range. And hopefully gave you some ideas and thoughts of what that evidence-based treatment looks like for those kinds of things. I've listed some resources here. So the Headache Relief Guide is my go-to resource. There's lots of videos on headaches, like what they are, what are migraines. That's really good. The Comfortability Program is a pain workshop that I'm trying really hard to bring to here, West Virginia. I know Pittsburgh has it up there. It's a one-day workshop for kids with chronic pain symptoms, and it can be any kind of disorder. They are moving more towards just any kind of physical kind of symptoms to make it more broad and reach kids with abdominal pain or even kids with functional neurological disorder to really kind of focus on that functioning piece. But it still has a great resource. They have teen talks and parent talks that individuals can join for free. And if they want to attend that one-day workshop, I used to do this back in Kansas City, so I'm familiar with it. So great resource. The WebMap app is a free chronic pain app that kids can use that kind of help gives them some guidance, developed by amazing researchers out in Seattle, who's kind of like one of the main pain researchers in children. And then these are just some of those videos that I use all the time for explaining chronic pain in kids. So some of my resources. So I'm going to stop here and just open it up for any questions or comments. I didn't include a specific case because really kind of the things I listed in treatment is what I do with my patients in that setting. But I'm happy if any of you have any patients or have any kinds of things you want to discuss. I'm happy to open that up for questions and time.
I'm going to go ahead and stop the recording. Give me 1 second.
Mhm.